Happy to be with you today. We are very honored to have Professor Schneider and Dr. Otiso with us. Helen Schneider is from South Africa. Many of you probably know her. She is based at the Western Cape University in Cape Town. She's a research on health systems and policy research, and most of her research is on community health workers, community health systems, primary health care, district health systems, and governance. Helen will start the webinar. She will present a quite challenging view on the tensions, or how could I say, the tensions between going for best practice approaches, where strategy would be to have practices which would be universal and validated elsewhere and then implemented across countries, versus an approach that she proposed to call the best fit approach, which is focusing much more on the local context. Of course, our heart, most of us will go for the second option. Still, I think this is something to reflect on, because indeed in our industry, many of us are very actively involved in promoting solutions which have been developed outside by me among others. Well, let's see. This is still at a hypothesis, so we are of course very curious to listen to Helen, and then we will listen to Lilian. Lilian is from Kenya. She works for an NGO in Kenya, LDCT. She is a program director there, and their programs focus on HIV/AIDS, gender-based violence, community health, and quality improvement. So Lilian is leading USAID-supported project, SQALE. I hope I pronounced it correctly. A project implemented jointly with the Liverpool School of Tropical and Medicine. And her presentation will focus on quality improvement in community health worker programs. And of course, we'll try to make links between these two presentations. So we hope that you will enjoy the webinar. Okay, Helen, I see your slides are coming. Welcome.
So thanks, Bruno, Sanjita, the team at the Collectivity for inviting me to present in this webinar. And thanks to all of you who've joined the conversation. It's wonderful to have such an incredible group of people actually as part of this. So in the vein of the theme of the unfinished agenda, what I propose to do in the next 15 to 20 minutes is make the case for a best fit agenda in the design and governance of national CHW programs, an agenda that would set aside a much more established best practice agenda. And the way I propose to do that is firstly by saying why I think this is a relevant distinction to make, and in fact how this distinction has been described by others. It's quite a well-known distinction in a number of fields. Then in making the case for a best fit approach, I will then go on to look at what I understand the requirements are to develop a best fit approach, looking at questions of context, history, and governance, and then finally end off by examining the implications of this for a knowledge generation agenda. So many of you will be familiar with the WHO Guideline on Health Policy and System Support to Optimize Community Health Worker Programs. It was a guideline launched last year to coincide with the 40th anniversary of the Alma-Ata Declaration, and it represents the culmination of a very rigorous international process to collate and synthesize the evidence on the health system elements of community health worker programs. It involved more than a dozen teams across the globe, bringing together what we know about community health worker programs, and quite nicely represented by this graphic, which I picked up from the core group listserv, and synthesized into 15 key roles, you can see them numbered there, that work across, if you like, the life cycle of CHW programs. And for each of these 15 different elements, the guideline proposes a set of key priority recommendations presented in an incredibly accessible format for each of the different elements. And here's an example that I've extracted specifically on supportive supervision. So it lists there 5 key recommendations for the development of the supportive supervision function in CHW programs, the first of which is defining appropriate supervisor-supervisory ratios to allow meaningful and regular support. It goes on to look at questions of mentoring and coaching. But an important caveat is attached to these guidelines, which I've reproduced there under that recommendation, that the guidelines should not be viewed as a blueprint that can be uncritically adopted. It should be seen as a critical overview of evidence and a menu of interrelated policy options and recommendations, which we might call best practice, which need to be adapted and contextualized to the reality of a specific health system. So that now speaks to the question of best fit. How do these universal prescripts, if you like, around best practice become part of the reality of specific health systems? And that takes us to then the distinction between best fit and best practice approaches. What exactly do we mean by this distinction? Well, it's, as I said earlier, invoked in quite a number of areas of discipline and practice. One of them is the field of human resource management, and another field where these ideas are being debated is in the field of governance. And here are 2 sets of authors that have worked with this idea of best practice and best fit. Both, as you can glean from the titles of these publications, are proponents of a best fit approach. So on the left-hand side, you have Brian Levy, who worked for many years in the World Bank, who's argued for a best fit approach to thinking about governance reform, and he argues it as such. The ability to describe the characteristics of effective programs, such as CHW programs, does not conjure them into existence out of thin air. Best practice approaches assume that all policies and institutions are potentially movable and can be aligned to fit some pre-specified blueprint. However, they cannot. The central challenges have less to do with the endpoint than with the journey of getting from here to there. Similarly, Ben Ramalingan and others from the Overseas Development Institute go on to describe the best fit as a concept stemming from governance efforts, which describes programs that are optimally adapted to the political, social, and economic context. Such programs can take advantage of a plurality of possible solutions, which can be deployed flexibly. They often work at multiple levels simultaneously, from community to national and even global policy levels, in order to facilitate and bring about change. And embedded in that idea, and something of the graphic behind on the cover page of this publication, speaks to the notion of complexity. So if we are going to grapple with the idea of developing a best fit agenda, and that we recognize that programs are not conjured out of thin air, what does it take, in fact, to develop a best fit approach? And what I'm going to argue is that, first of all, we need to develop a very good understanding of the context of CHW programs. So this is a graphic from a paper recently published by Kerry Scott and Asher George and Rajani Ved reviewing the state of knowledge on the Indian ASHA community health worker programs, really pointing to 4 key elements of CHW program context. So you have your CHW program here, you have a health service context, you have a community context. They are located in a broader health system context, which itself is located within a macro context. So thinking a little bit firstly about what is a health service context, here is a diagram showing the communication patterns in a local community health worker team with the local primary healthcare system. So you see CHWs numbered here from 1 to 11. They engage with a range of facility players, nursing staff, the operational manager, team leader, in a very, very dense network of daily communications in order to do their work. This is, by the way, work done by a PhD student here at UWC, who's looking at ways of thinking about a bottom-up approach to supportive supervision. Tumelo then looked quite carefully at the nature of trust relationships in that larger communication network. And what she found is a much less dense network and very particular kinds of interactions that form the basis of trust relationships. If you look at the diagram, most of the trust relationships that people said they had were with peers, with other community health workers. The managers, the operational manager of the facility didn't really feature, and neither the team leader, actually, as the most trustworthy player. And if one thinks about then juxtaposing this understanding on those 5 recommendations on supportive supervision I showed you earlier, it raises a whole set of a new layer and a whole set of new questions about what is supportive supervision, how do we understand it, and how do we develop it. So in this complex set of everyday relationships and trust relationships, who is the supervisor? We haven't even mapped here the community relationships. Who is best positioned as the mentor, and what would be appropriate ratios in this local ecosystem of relationships? So the second element of context is in relation to communities. In fact, the Collectivity devoted a whole webinar on this a few months ago, examining questions of the community health system, what it is, and how to think about it. And this is one of those slides copied from that webinar, summarizing the findings of a literature review on the concept of community capability that looks at social characteristics, assets, and governance within communities that has a large influence on the functioning, in fact, of community health worker programs. So understanding the community context would be as important as understanding the health system context. The third layer of context, if you like, that I think is very important to pay attention to is history. And I've listed here a whole lot of several of the most well-known national community health worker programs. And all of these programs arise out of a unique set of circumstances, several of them out of changes in the political context, several of them emerging out of specific subnational experiences and experiments located within broader policy processes such as human resources for health strategies, or emerging from very particular needs and dynamics such as the response to HIV in South Africa that produced, in South Africa and in fact in the Southern African region, something of an associational revolution, the development of a large community-based care and support sector, out of which a national community-based health worker program has been fashioned. Those histories fundamentally shape the design choices in national community health worker programs. And in fact, there are very few countries that don't already have now some form of community-based care response, health system response. And those particular configurations emerge from particular historical and contextual factors that position programs along a range of different attributes listed there. For example, whether they're a volunteer or remunerated, whether you have a single cadre or multiple cadres, et cetera, and all of those would then need to interface with thinking on global best practice and how that global best practice would fit with particular configurations and these historical and contingent factors, which, by the way, change over time. So in the early phases of national community health worker programs, they tend to have particular approaches and forms which evolve and change over time. And one of them is the shift from volunteer to remunerated approaches to CHWs. So in order, the last requirement for a strengthening, if you like, a best fit approach would be to develop the capacity for best fit governance at national and subnational level. And in a recent paper, I proposed a framework for thinking about what best fit governance entails, involving 5 key functions, really processes of governance distributed across levels of government. And the first would be to think about policy mandates as a negotiated fit between evidence histories and strategies, to think very carefully about the nature of those local relationships that I represented earlier, to think about aligning the systems of those programs, the best practice of which is spelled out in the WHO guidelines, with existing other systems, the need to think about change and learning as a feature of those systems, and the central importance of political support in maintaining those systems as a bundle, if you like, of best fit governance practices. So what would be then finally approaches to thinking about developing knowledge in for best fit practices? Well, what I would like to suggest, and what several people have suggested, is that it does require paradigm shifts in thinking about how we generate knowledge, and certainly new agendas of knowledge generation. So in a recent debate held on the core group listserv, a question was posed: what is the most important innovation taking forward the CHW guidelines? And Eric Sario, who contributed to this listserv, who's also has done a lot of thinking about best fit approaches, made this following provocative statement: the quest for the most important innovation is a central planner-generated utopia, which can damage the generation of locally driven innovations captured for learning by regional, national, and global actors. The most important innovation is to reject the concept of the most important innovation in favor of creating conditions for the emergence of innovations at national level. He went on to say that actually we should be seeking to aggregate globally, learning from these de-globalized national efforts, in contrast to developing first global agendas adapted at national level. Ben Ramalingan has also, and colleagues in the monograph I profiled earlier, emphasizes the importance of shifting from the what to how, and I think Lillian is going to be speaking to this. They're saying there's as much need for rigor and science in answering questions of how to work as there is in answering questions of what works. So what I think is that we need to engage very carefully with the methodologies of what a best fit approach requires. Many of these players would emphasize the relevance of complexity science and all the tools and methodologies that rapidly growing field is offering. Secondly, one needs systems and capacity for adaptive learning. So it's not just about research, but it's also about thinking how systems can learn. It relates to strategies of quality improvement and the use of rapid improvement cycles, an emphasis on learning by doing in systems, and the ability to harness the tacit knowledge that local players have. It also would be greatly advanced by the development of holistic case studies, of local, regional, country experiences that look at phenomena carefully in context. But we should caution about seeing this kind of knowledge as purely local and parochial and anecdotal, and actually to consider, as Eric Sario has proposed, we can aggregate this kind of local learning globally. So, for example, Tumelo's complexity analyses, social network analyses, how can that understanding of the notion of a relational ecosystem complement the 5 best practices, the understanding on which the 5 best practices are proposed for supportive supervision? How do we bring those kinds of understandings together in a more balanced global conversation? And what I would propose actually is that we actually need something called best fit scholarship. But there are challenges to doing that. And here is a graphical representation of partnership networks in research on community health worker programs, in specifically researching these programs in low-income countries. And what you see in those purple lines is that the model of scholarship is very much a north-driven one, engaging with particular southern localities. And if one took away those pink lines, you would see relatively little south-south connections. And if they did exist, they would be mediated by the middle-income countries. So very few opportunities at present to allow for south-south learning. And in fact, for a kind of reverse approach where this southern scholarship can inform global thinking. So we need, in my view, a much stronger capacity for embedded research in this field that can bring together a best fit agenda with a best practice one. So those are my views, and thank you very much. Handing over to you.
Thank you, and thanks, Helen, for setting the scene there. I will be presenting some work that we have done on community health programs, really addressing what has been found to be missing in many community health programs, and that is quality, especially as we talk about or we think about the aspects of scale up and universal health coverage, which is what a lot of countries, including Kenya, are saying related to community health work programs. And so in the presentation itself, over the next 15 or so minutes, I will be able to give you a background of the Kenyan community health strategy and what we did in the SQALE model, which implemented quality improvement, the results for that, and then what we see as the considerations for scale up for anybody who would like to learn and take this up more. So I'll begin by describing the Kenyan Community Health Strategy. This has been in existence since 2006, and it was revised in 2014. And within this strategy, what is described is having a structure where we have a population of 5,000 people forming a community unit, served by 10 community health volunteers, and supervised by 5 community health extension workers. But in reality, we have not been able to reach the 10 community health extension workers, and in most cases we have 1 or 2 where we have more community health volunteers. And the volunteers are the ones who are responsible for providing the primary health care information and services and referral to the primary health care facilities, while the community health extension workers supervise them at those different levels. The strategy is defined in such a way that the community health volunteers report their data to the national DHIS system and also report to their supervisors on a monthly basis. So coming to the SQALE project in particular, this is a project that is a follow-on of an EU-funded project called Reach Out that was multi-country, aimed at strengthening community health systems. And within Reach Out, we were able to test or implement models for supervision of community health workers and quality improvement. And this was a 6-country study, and in partnership with led by Liverpool School of Tropical Medicine, and we implemented the Kenyan context. So for SQALE project, this started from 2016 to 19, and the goal was to scale up what we learned in Reach Out around scaling up the quality improvement approaches in different community units and at different levels, and then seeing what results we'd get, especially in reducing maternal and child deaths. So going directly to the SQALE model itself, we applied principles that are aligned to community programs, where the key issue here was simplifying what we were doing. And we made sure that we aligned our program with the National Ministry of Health standards, models and tools, and we implemented it within existing community health programs. So we did not go outside and create our own community units. We worked with the government ones, with the county who are the Kenyan subnational level equivalent. We focused on improving data quality because we know that without good data quality, then we cannot be able to implement quality improvement approaches. And then we had a small set of quality indicators. We realized that when you're working with community teams, it's from the health perspective, it's always very easy to want to find out all sorts of indicators. But we focused on having a few that we could be able to track and that many people could be able to follow. And they were all on maternal and child health. And having good teams and forming teams and being able to improve the team approaches as we went along. We also really focused on strengthening community facility linkage, which we knew has been a challenge in many community health programs, especially in Kenya, where the facilities may not recognize the value or the role that is played by community health programs. So within SQALE, we used a cascaded approach of trying to ensure that we implement the QI approaches as we know them. In the country, we have been having QI in the form of Kenya Quality Model for Health for a long time, actually, with training since 2011 and even before that, but it had not cascaded to community level. And so our goal is to use these same approaches like the whole plan, do, study, act cycles and simplify them to be used at this level. And so we have a cascaded approach, which it ensures that the process is led by the Ministry of Health leadership at different levels, and then the roles and responsibilities for each level are defined at inception, and each team member knows their role there. And our focus was more on the community level width, which consisted of community members, but also the facility staff. And they had to collect and use their data for QI. And then we also had the sub-county teams who then the community would report to, and they were also involved in collecting and using their data for quality improvement. So to make this process work and to actually be able to share the learning from the community level, we used a phased training approach. We recognized that overloading the teams with concepts and complex theories of QI and PDSA and all those things may not work. And so we took a few concepts and divided the training into 3 phases, where we provided short training with periods of implementation and support. So as you can see here from phase 1, we focused on the basic QI concepts and formulating the teams, and then looked at data quality and asked the team members to bring their own data, use and learn and look at the quality of their data, then go off for a period of about a month to improve their data such that when they would come to phase 2, they would be taught how to present and analyze their data, and then do their problem identification and root cause analysis and come up with change plans. Then the second implementation phase would go on up to 6 months, where they would now be implementing this, supported by a lot of coaching and supervision from coaches who are from the project team and also from the Ministry of Health. Then in the third phase, we had evaluation of change plans and sharing and learning through learning events that we've defined later and really become a good platform for exchanging and for learning, which is critical to this approach, and especially for building community teams. So this slide is showing an example of the data issues that we had to deal with. So this, from the picture there, you can see this community health volunteer had decided to use cardboard because they could not access data tools. And that's when we realized that we have to focus on data quality. So our focus areas were improving data quality, antenatal care attendance, skill delivery, and growth monitoring for children, as well as immunization. But we also went beyond just the health outcomes and looked at quality indicators like patient experience. So what is the quality of services at the household level? And also looking at equity in terms of ensuring that vulnerable groups were targeted by these groups. And all this was the community teams themselves learning and being exposed and knowing how to go and identify that these are our vulnerable groups and doing something about it. So for example, adolescent girls and their access to antenatal care services. So what results did we see? The first and most basic one, and this one we learned during the reach out study itself, was that the teams were able to understand and buy in the QI approach. The diagram there shows how a team was able to do a root cause analysis and present it on their own. So this was a presentation during a learning event where they were able to showcase their own root cause analysis, and others also showed how they had very good understanding of why in terms of doing their problem identification and using it to come up with the solutions or identifying what was causing them, the challenge they're having, for example, in the low antenatal care visits. And this approach was taken up successfully by 27 community health unit teams, 9 sub-county health teams, and 3 county health management teams. So the results we see here was started with the issues of the data quality assessment. As I mentioned, we focused on improving data quality so that then the data could be used for decision making in terms of the problem identification and problem solving. So this graph here shows what we found at a baseline when we did, from a research perspective, we actually did a data quality audit assessment of the existing tools, assessing the concordance between the reports that are written and what is submitted in the National Health Information System. And it varied from 0 to 60 to 92. But by the time of completing the study, then they were at about 100%, majority were at 100%, with a few going above. But again, these are things that they kept resolving as they went along. From a qualitative perspective, we were also able to get information on the comments like this one, which came from a community health volunteer who actually admitted that they used to cook data. So he said the difference was one, data. We used to cook. You know, the previous paper was so complicated, but at least now we know what we're feeling. And that's because we spent a lot of time working with the work improvement team to work with them to make sure that their data was accurate and somebody cared about it. This is another example presented by the team. So as I mentioned, we were very focused on making the approach very simple, using available resources, and the team making sure that we can sustain this even beyond the project. And so the teams would generate their own run charts using Manila that was available to them where they were. And in this case, this shows how we improved the community facility linkage. The team here was able to track that with their referrals from the community, shown by the line at the top, then they saw the fully immunized children at the link facility increasing with time. And they also told us or informed us how the facility staff finally understood the value of community health workers and started the referrals were then accepted, and the teams were able to complete the referrals and actually achieve better outcomes at the facility level. I mentioned on how we looked at the patient experience and patient satisfaction. So we tracked improvement in quality of services, and we gave, as a team, we were using MOH tools, but as a project, we developed a new tool known as the community follow-up tool, which would be administered, and somebody given the task by the work improvement team would give somebody the responsibility of going to the household and following up a household where a community health worker had visited and seeing what happened during the visit. Did he actually check the mid-upper circumference as they were supposed to? Did they ask about the mother-child booklet, or did they give you information as required, and were you satisfied with the visit? So this is just one example of the results that we saw, where before, at the baseline of the intervention, it was at 45% MOAC uptake, and later, towards the end, it was 79% uptake. We have also seen some interesting results emerge in this. The project has been able to inspire innovation. We've built the capacity of the teams to think about having their own local solutions to their problem. And this particular case is a community health extension worker who has some skills in developing mobile applications. And he recognized that his team was struggling with data collection at the community level. So he developed a mobile app. He was able to share the app with the community health teams, and they were able to collect their own data. And as you can see from the diagram on the right, there are smiley faces and there are emojis showing that this is good data or bad data. And it's quite useful for them. So I was saying that we also focused on achieving policy impacts. So from the project, right from inception, we knew that we are not doing this just for our own sake, and we wanted it to be sustained. We could only go to 3 county teams and 9 sub-counties, and we have 47 counties in the country. So we were deliberate to make sure that we learn as we go along and use the feedback that we get from the teams, and through an iterative process, come up with a manual that can be shared. And that manual was completed and adopted by the national government. As you can see there, this was a launch event we had recently to just launch the facilitators manual so that it can now be shared across the country by all the teams. And this is also available for any other country to use, and we'll make sure that it's available through Collectivity and other platforms that we can share such resources. We also helped to revise the standards for community health services, and we made sure that this was based on input from the work improvement team members, recognizing or utilizing the principle where the beneficiaries must be involved in the process. So we involved them to revise standards that had been developed by government, and now those have also been taken up by government. And we also have seen that we can be able to sustain these approaches. We've done some studies on the costs of doing this, and we know that training is the largest cost. But the county teams have gone ahead and budgeted for sustaining quality improvement through supervision and coaching visits. And they've also learned that they've also found ways of sustaining community health programs by creating health bills to pass to their county assemblies for community health workers to be paid, and therefore to make them functional, and then strengthened by approaches like QI that we have done. So in terms of the key lessons we've learned, which we think are useful considerations for those who would like to scale up this approach, we would like to see this. We recognize that this is a pilot done at a small scale. We have learned some lessons, but we implemented this mainly over a period of 1 year, and the results then need to be tested over a longer period of time or at a larger scale. And one of the immediate lessons we learned is that in some cases we had more than one community unit linking to one facility, but we only reached one unit because of limitations. So if for those who would like to take this approach, it would be good that if you have the number of units linking to a facility are all working together and are trained on this approach to be able to see impact. And at the same time, we do need that facility to also be implementing QI itself, and then have that joint facility community QI team. The other major thing that we've seen is we tested, in our second cycles, we asked the teams with county leadership, to prioritize what are their health needs. So for example, some counties selected skill delivery as a challenge for them. Others selected 4 antenatal care visits, for example. And through this leadership of the counties, we were able to see the teams all pulling their resources towards focusing on that one thing, which is the county need, and then being able to achieve great impact. So these would be good lessons for people to take up. The other third thing, which it becomes a challenge if it's not available, is if community health workers, if the community health program is not functioning in terms of the CHWs are not trained or they lack tools, then it becomes very difficult to even implement QI. So you need to have those basic resources or the basic requirements for a community program to work, and then you build on QI, which then makes it very effective and efficient. And finally, is the aspect of continuous learning. We learned that learning and sharing events was very important. We held learning events at the end of the cycles, and those were moments of sharing, and they were fun, they were competitive, and people were able to learn from each other and again present their own work and compete with each other. And those forums created that kind of platform where people felt challenged and discovered how they can improve themselves. So the other kind of forums are this, for example, now when we share in webinars, that we've seen also work. And finally, there has to be also sustained coaching, mentorship, and supervision provided by the experts from the county teams, from different projects, to make sure that then the lessons that are learned are sustained by the teams and are not just left off to struggle on their own. So this is just an image of how we're able to celebrate the good teams, and this we've seen is a major motivation that helps to sustain the project and helps to keep the learning going. So I'd like to acknowledge all those who are involved in all this, and we have provided some resources, and you can also follow us or check on our website to see more resources that can then be used by anyone in different settings, and we're available to provide that support to make sure that it can be implemented and it can be adapted to different contexts, even if we've done this only in Kenya so far. Thank you very much.
Thanks a lot, Liliane. That's super interesting, and it's a good illustration of the ideas introduced by Helen. May I invite Jerome Pfaffman from UNICEF New York to say a few words? Jerome, the floor is yours.
Hi, everyone. Thank you very much for giving me the opportunity to speak and comment. Just wanted to say first that I really appreciated the presentation made and the discussion that it will raise. I just want to share a few comments and maybe start by some initial question back to the presenters. The first comment is that I really think we're moving with Helen Schneider's presentation. We have been seeing how much it is important to take community health worker programs beyond the program itself and embed this in a community health system approach. And I really think collectively as a community, it's something we need to reflect on our practice and see how we can strengthen this perspective, this approach to community health worker programs. And I think one of the key, which is my second point I wanted to raise, and one of the key ways to do this is start to reverse the way we discuss and present these community health worker programs and try to get more of a bottom-up approach. We need to get more information, more feedback, more knowledge produced from the ground. And I really appreciate the work done by the community of practice in that sense. And to conclude, building on what Helen and Liliane has presented, I think really the moving from what to do, that I think the evidence is now here, and there is a lot of lessons learned on the how to do it is critical. That's what was one of the key messages from Helen's presentation, and making sure that we don't apply models to different contexts without adapting, without reflecting on the specifics of each community system that are in place, so we can have the best outcome for the community health worker programs, but also to make sure that communities' capabilities are strengthened and communities get empowered through these processes. Thank you anyway very much. Thank Gita and Bruno for organizing this webinar and for the presentation.
Thanks, Jerome. That was a nice message also coming from UNICEF, a very important stakeholder in this area. We are coming to the end of this webinar, so I want to thank Hélène and Liliane again. This was your interventions were really helpful. We are not just doing best practices. I think many of us are very aware that context matters and that we have to involve stakeholders, and we have done things, but I think we can do better and we can do more. I believe that leadership and should come also from the top in this respect, from leadership at country level, but also at global level. So there are a lot of practices to be changed. So I really took your point, Hélène, that this is an agenda already promoted by the quality improvement group and movement. I fully agree. There is no shortcut. We have to build this capacity of improving things, and this will be a long journey, but I see countries moving to that and with the help of their partners. So thanks for the many of you who were with us. This was one of the biggest webinar we ever had in terms of audience, and we are very happy and proud of that. I think our series is getting more and more attention. So there will be more webinars organized by Collectivity and by the Community Health Committee of Practice. So stay tuned. If you are not yet member of the Committee of Practice, please join us. This is the place where we will share the link to the YouTube recording. This is also the place where we will share the PowerPoint and continue the conversation. So on that, let's stop here. Thanks a lot to all of you, and let's stay tuned. So thanks, Hélène, thanks, Liliane, thanks, Sangeeta, and thanks, Jerome.